Hey guys, hi, good afternoon, everyone. I want to quickly talk about narrow drugs with narrow therapeutic index using digoxin as a clinical example. The thought behind doing this is providing you with tools to um, examine medicines that may be toxic, you know, at very little variances in their dose. You see one of the reasons why, or two of the rules around why we classify some drugs as narrow therapeutic index. They're very much different, or we treat them a lot differently from how we treat, for example, over-the-counter medicines and other prescription medicines. And this is because slight variations or um, little variations, like twice the standard deviation for um, a therapeutic dose, will lead to significant toxicity in the patient being treated. This is much different in medicines used over the counter and those used as other prescription medicines. So, by way of outline, we're going to look at definitions for narrow therapeutic index. We're going to look at the pharmacokinetic, pharmacodynamic considerations for narrow therapeutic index drugs. We're also going to quickly look at digoxin as an example, and then we'll see a few calculations as an example. Um, at this time, there still doesn't exist a consensus across the practice areas for what constitutes a narrow therapeutic index drug. But then in fact, even the terms are different depending on what it is being used for. For example, some researchers refer to them as drugs with narrow therapeutic range, and then that's especially those who are in clinical research. And then you find people refer to them, for example, policymakers could use terms like complicated drugs. That's, for example, when you're working with policymakers and you're trying to get certain approvals or certain considerations for those medicines. So you use very simple terms like complicated drugs or say critical use drugs, right? And but then the idea is that there should be central loci around which all of those descriptions will revolve around, and we can find that by using one of the definitions from the FDA that says um, for a drug to be classified as a narrow therapeutic index drug, it has to show evidence that the drug produces or exhibits a narrow therapeutic ratio, uh, meaning that there's less than twofold difference in the median lethal dose and the median effective dose. That's LD50 and ED50 value, or they have a less than twofold difference, the minimum toxic concentrations and the minimum effective concentrations in the blood. And safe and effective use of the drugs requires careful dosage titration and patient monitoring. Um, the careful dosage titration and monitoring is required because of some of the considerations that I'm going to get into shortly. But just to inform us, the LD50 is not like a commonly used term anymore, especially since there are very, very important drives now to clarify the rights of animals during drug testing. So it's essential to, an update is essential. So, for example, an update comes around for the FDA's definition to say that a less than twofold difference in the ratio between the lowest concentration at which the clinical toxicity commonly occurs to the median concentration providing a therapeutic effect. So in that way, you eliminate the LD50 which connotes animal cruelty in clinical practice. If you look at the slide on your screen, you see that for narrow therapeutic index drugs, which is the B drug, there's a very narrow space between what you consider as the lowest drug at which, the lowest dose at which um, uh, toxicity appears and the mean effective concentration. So it's important to note that the dose is smaller for, okay, and like I said, so this represents normal drugs, OTC and prescription medicines, and this represents narrow therapeutic index drugs. Moving forward, I mentioned that we're going to see the pharmacokinetic, pharmacodynamic considerations that help us decide on monitoring, on those on those individualization and other considerations for clinical monitoring. And one of that is one, to be clinically useful and predictable, narrow therapeutic index drugs must have low intra-subject variability. So between the time when you start or initiate treatment to other consecutive doses, there have to be some sort of relatability. So it's either the variations are based on renal clearance, the variations are based on something that is measurable. It must not vary widely, outside of what is measurable. And then secondly, in contrast, the inter-subject variability of PK/PD measures must be relatively high for narrow therapeutic index drugs. Therefore, therapeutic monitoring is needed for dose individualization. So between patients, there will be observed differences, and this is one of the reasons why individualization for these medicines is important, especially for medicines like digoxin that are life-saving medicines. Even though, as we've come to understanding more, there have been differences in how digoxin has been used. Now, when the inter-subject variability of the PD measure is high, note that PD monitoring is what is required. Now, conversely, if the subject variability of a PK measure is high and a PK-PD relationship exists, of course, PK monitoring will be used for dose optimization in such a patient, right? Just to mention that. I mean, that's a direct interpretation of what you have in number 2. Now, just still within the same example, a good example is also warfarin. In warfarin, you monitor pharmacodynamic response from mean time of warfarin. It plays an important role in titration and dose optimization for therapy. Whereas measurement of plasma concentration is a PK parameter, has little utility in optimizing therapy for warfarin. The optimal dose of warfarin varies widely between patients because of extrinsic and intrinsic factors such as PK variability, genetics, and diet. And that high intersubject variability in the PD response necessitates PD monitoring for individualization of warfarin dose. Okay, the low intrasubject variability in the PD response to warfarin enables the prescriber to predict clinical response within that particular patient. So once you individualize treatment for a particular patient, if the patient, for example, renal function and other important parameters do not change suddenly, then you can predict what the next proton time will be. If you increase the dose, you can predict what the next proton time would look like. In contrast, for cyclosporine, phenytoin, procainamide, these are also examples of narrow therapeutic index drugs. They exemplify drugs with a direct PK/PD relationship, similar for digoxin. There's some PK/PD relationship, but of course, the PK/PD relationship comes when steady state has been achieved. Is relatively high. Here, monitoring of plasma concentration is critical in achieving optimal efficacy and safety. Yet, PD monitoring may also be important for the optimization of therapy. That's also important for patients that are being treated with digoxin. So sometimes you, of course, once you establish steady state concentration, you can relate steady state concentration to drug effect. So sometimes you monitor clinical efficacy to adjust the PK parameters as well. Now let's quickly talk about the drug of the moment, digoxin. It's a cardiac glycoside in clinical use. It's used primarily in the treatment of congestive heart failure because of its inotropic, that it increases the force of contraction of the myocardium, and it's also used in atrial fibrillation because it increases the speed of contraction of the heart. The role of digoxin in the treatment of each of these is the state has changed in recent years. Like I said, digoxin has become better understood, and so the way it's being used has changed. For example, in the treatment of chronic congestive heart failure, ACE inhibitors are now, and diuretics are now the primary pharmacotherapeutic agents, with ACE ARBs as well. So you have spironolactone and beta blockers playing key roles. It's important to note, for example, for those of you who are those who will be getting into clinical practice, you'll find out that the roles of, for example, spironolactone in congestive heart failure goes beyond just serving as a diuretic. It has some global benefits. For example, it modifies the shape of the heart. So over the course of use, it reduces the excessive musculature around the heart vessels. So by reducing that excessive musculature, it also reduces the excessive need for oxygenation. So it reduces the demand of the heart on itself, and by so doing, it improves the heart's ability to perform its function. Okay, so spironolactone is much more than a diuretic when used in this case for congestive heart failure, or even for cardio or other heart defects, for example, excessive enlargement of the heart, right? So for the treatment of acute or severe heart failure, agents that decrease cardiac preload, like diuretics and nitrates, or afterload vasodilators and ACE inhibitors. ACE inhibitors have effect both on afterload and preload. And that's one of the reasons why it is not usually the first point of call when somebody presents with heart failure. So most times you want to stabilize the patient before you initiate ACE inhibitors in patients. Okay. This is like, well, it's a clinical class, but then just to help you understand the basis for the use of digoxin as a cardiac glycoside in this current time. Now, let's talk about therapeutic and toxic concentrations that help us define that digoxin is a narrow therapeutic index drug. When given as oral or IV drug doses, the serum digoxin concentration time curve follows a two-compartment model. Of course, we have discussed about two-compartment models. First, the first part of the curve, or the A part of the curve, has a steep, drop, and we said in that consideration that that first part of the curve is distribution. It's the time within which the drug is being distributed from the central compartment into the secondary compartments, which are less perfused compared to the primary compartments. And during that phase, we do not really consider elimination of the drug because essentially what is happening at that point is distribution. But within the second phase of the drug, which at that point is where the drug achieves steady state concentration, and then elimination begins to happen from the central compartment of the drug. That second, which is the long which is the long phase, is really important. But it's important to note that digoxin has a long and large distribution phase that lasts between 8 to 12 hours. So it's important in some patients who have, for example, renal kidney failure, or whose creatinine clearance has been severely impacted. You may have you may have distribution phases that are, much longer, or sorry, it takes much longer to achieve steady state concentration. So in some people, you'll have maybe about 2 to 3 days before you achieve steady state concentration. Now, during the distribution phase, digoxin in the serum is not in equilibrium with digoxin in tissue. We already know that. So digoxin serum concentration should not be measured. In fact, if you take your measurement, you have high concentration of digoxin within the central compartment, and you will not, at that point, you will not be able to have clinical effects of the drug. So if you as a clinician or you as a pharmacist, you're monitoring your patient and you see this incongruence, it's likely to have sampled earlier than you should have sampled. Okay, so it's important when drug distribution is complete, digoxin serum and tissue concentration will be proportional to each other, not that they'll be equal to each other, so that digoxin serum concentrations reflect concentrations at the site of action, or it is equivalent to what's going on at the site of action. When digoxin serum concentration is very high, okay, I already mentioned that, but the exhibiting signs or symptoms of digitalis toxicity, you should consider the possibility that you sampled way too early, sampled before distribution was complete. There's a great deal of inter and intrapatient variability in the pharmacodynamic response to digoxin, which is why you need to individualize the dose. Clinically beneficial inotropic, that force of contraction effects of digoxin, are generally achieved at steady state serum concentrations between 0.5 to 1 nanograms per ml. In some patients, you may need to opt out about 1.2 nanograms per ml. Steady state digoxin serum concentrations above 2 nanograms per ml are associated with increased incidence of adverse drug reactions at doses of 2.5 nanograms per ml, or above 50% of all, or above 50% of all patients who exhibit some form of digoxin toxicity. So always try to ensure that your digoxin steady state concentration is kept below 2 nanograms per ml. Most digoxin side effects involve the GI, and of course you have visual disturbances as well. You also have cardiac side effects. Do not expect that the minor side effects like the GI side effects will happen before the major side effects. Okay, so whichever one, once there's a new symptom of happening to once the patient reports any new symptom, which is very important. So when you're educating the patient, to tell them once there's a new symptom that comes up, regardless of what it is, a new headache, if it's color or visual disturbance, please report immediately. Okay, should be noted that also in the case of life-threatening digoxin overdose, digoxin antigen binding fragments or digoxin immune fab are portions of digoxin specific antibodies that can be used to rapidly reverse those symptoms. That's very important. That's a specific antidote for digoxin poisoning. Now let's quickly look at digoxin in terms of clinical monitoring and basic clinical pharmacokinetic parameters that ought to be looked at. So clinical monitoring, as pharmacists, you your patients who are receiving digoxin for heart failure, you will need to monitor the common signs and symptoms of congestive heart failure in those patients. For example, you're looking at the left-sided failure Be watching out for dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, tachypnea, cough, mucosis, pulmonary rales, or edema. You're looking at S3 gallop, pleural effusion, right? So that's very important. You monitor to ensure that those symptoms are getting better, okay? And if it's right-sided failure, of course, abdominal pain, you look out for anorexia, nausea, bloating, constipation, ascites, peripheral edema, jugular venous distension. You want to look out for hepatojugular reflux. And then generally, of course, if you have the two chambers failure, you will usually, or even any of the chambers failure, you would usually have fatigue, weakness. So you have people complain. Once they're exerting themselves, we will hear complaints about fatigue, weakness, nocturia, CNS symptoms, tachycardia, pallor, digital cyanosis, or cardiomegaly. Okay, all of those should be monitored, all through the patient's treatment. For pharmacokinetic parameters that you should also measure clinically, the primary route of digoxin elimination from the body is the kidney via glomerular filtration and active tubular secretion of unchanged drug. That handles about 75% of excretion. So this is very important, and that's why if there's any renal dysfunction, then you should take note of that in your calculation. The remainder of a digoxin dose is removed by hepatic metabolism or biliary excretion. Primary transporter involved in active tubular secretion and biliary excretion are the P glycoproteins, and it's important to enterohepatic recirculation, that's the reabsorption of drugs from the GI after elimination in the bile, also of course for digoxin. Digoxin can be given as an IV injection, as a tablet, capsule, or elixir. The most commonly used here in Nigeria include injection, as intravenous injection, or as tablets. The average bioavailability constant for the tablet, capsule, and elixir are 0.7, 0.9, and 0.8 respectively. Digoxin is not usually administered IM due to erratic absorption and severe pain at absorption sites. Now let's quickly look at pharmacokinetic dosing methods. So here we want to look at what model, like we have mentioned before, digoxin dosing follows a two-compartment model, and we can look at it in terms of a linear model, and we can look at it also in terms of a non-linear kinetic model. Okay, so in terms of steady state concentration, we can calculate the steady state concentration using CSS, that's the constitutional steady state concentration, is equal to the bioavailability multiplied by the dose per day and divided, all of that divided by the clearance per day. Okay, that gives you the concentration at steady state. You can also look at the loading dose as the concentration, the steady state concentration times the apparent volume of distribution of digoxin in that patient divided by the bioavailability fraction. Of course, if you're administering the loading dose as, for example, a bolus injection, your F will be 1, right? Because all of your dose goes into the central system at once. But then for oral doses, of course, you'll be using 0.7. For capsules, you'll be using 0.9, and for your elixir, you'll be using 0.8, right? Please take note of that. Those differences or those peculiarities may come out, when you're attending to patients, when you're answering a question, right? Creatinine clearance can also be estimated using the Cockcroft-Gault equation. When the patient is not obese, you can use that to estimate the patient's creatinine clearance. The equation is as indicated. And then if the patient is obese, of course, you use the Salazar and Corcoran equation, which is as presented as well. You can also use current digoxin serum concentration of a patient to alter their next dose. Take, for example, the patient is already under treatment to achieve steady state concentration of about 0.9 nanograms per ml. At that point, if you're not getting adequate clinical response, you can decide, okay, let's increase the steady state to let's say 1.2 nanograms per ml, right? The logical thing to do would be to use one of two methods. Either use the linear method or use the pharmacokinetic parameter method. The linear method, if you already have the old dose that you're using, you have your current CSS, you have your anticipated or your new CSS you want to achieve, you can do a linear calculation and get your new dose for achieving the new required serum concentration. If you use a pharmacokinetic parameter, that might also give you something a bit closer to something that's more accurate, because that takes into cognizance the creatinine clearance of the patient, if it has changed. It also takes cognizance of the patient's weight and helps to adjust if the patient is obese or if the patient is obese or normal weight, right? Here's a sample question, which I'm going to solve in the next video, and I will show you how to work around that. Just to say that these are a few considerations around how the pharmacokinetics of digoxin in narrow therapeutic index drug is considered. These are a few practice questions, and I want to say thank you for your audience. If you have questions, we're going to take a tutorial class, so please be there and we'll take that together. Thank you. Have a good day.